that?
Dr. Simon. Dr. Simon Demello. Over to Dr. Simon, please.
Good evening, sir.
Ah,
Am I audible, sir?
yeah, you are audible. Go ahead.
Good evening. I am Dr. Simon Demello from Jagjeevan Ram Hospital. I will be talking about equal pressure point. So the definition of equal pressure point is, it is the precise location along the tracheobronchial tree where intraluminal, that is airway pressure, and extraluminal or pleural pressure become equal during forced expiration, leading to airway collapse and expiratory flow limitation. Thus, equal pressure point develops when transpulmonary pressure gradient becomes zero. Now, transpulmonary pressure gradient is the difference between the pressure inside the airways and the intrapleural pressure. This gradient is positive during inspiration and it becomes negative during forced expiration. At rest, intrapleural pressure is subatmospheric or negative. It is due to the recoil of chest wall and lungs away from each other. This pressure becomes more negative during inspiration due to active contraction of the diaphragm and inspiratory intercostal muscles, leading to expansion of the thorax. As a result, transpulmonary pressure increases and causes expansion of the lungs. The transpulmonary pressure becomes greater than the inward elastic recoil of the lungs, and the expansion of lungs creates a subatmospheric pressure in the alveoli, leading to airflow down the pressure gradient into the lungs. As long as there is a difference between the transpulmonary pressure and elastic recoil of lungs, there will be airflow into the lungs. At the end of inspiration, the inflated lungs exert a higher elastic recoil, which becomes equal to transpulmonary pressure, and airflow ceases. During passive expiration, the diaphragm and inspiratory intercostal muscles will cease to contract and start relaxing. This causes inward recoil of the chest wall and decrease in lung size. The intrapleural pressure goes back to its less negative baseline value, which decreases transpulmonary pressure, making it less than the elastic recoil of the inflated lungs. This causes passive recoil of the lungs to their baseline dimensions, which causes alveolar pressure to surpass atmospheric pressure and causes air to flow out from the alveoli into the atmosphere. In quiet expiration, in a normal patient, pressure in the lumen of the airways always exceeds the intrapleural pressure because of upstream elastic recoil pressure transmitted from the alveoli. The effect of this elastic recoil pressure diminishes as the air flows downstream in the airway towards the mouth. Now coming to forced expiration. During forced expiration, due to active contraction of the expiratory muscles, the chest wall and diaphragm are pushed further inwards into the thoracic cavity, along the direction of elastic recoil of lungs. This causes intrapleural pressure to become positive and transpulmonary pressure gradient becomes negative. So in forced expiration, the positive intrapleural pressure may thus become equal to the intraluminal pressure at a certain point along the tracheobronchial tree. This is called as equal pressure point or point of critical closure. Beyond this point, the pleural pressure will exceed the airway pressure, causing dynamic compression of the airways and expiratory flow limitation. Thereafter, any increase in expiratory flow will not produce an increase in flow at that given lung volume. This is because increasing expiratory effort increases the pleural pressure to the same extent as airway pressure, so the transpulmonary pressure gradient will remain the same. This phenomenon is seen in normal patients only during forced expiration. However, in severe COPD patients, there is often flow limitation even during tidal volume expiration at rest. This is particularly seen in emphysematous patients who primarily have a problem with loss of lung elastic recoil. In disease states where there is increased airway resistance and loss of lung elastic recoil, the equal pressure point is encountered earlier during expiration. That is, it moves towards the alveoli and smaller airways due to greater intraluminal pressure drop. Smaller airways lack cartilaginous support and are thus easily compressed during forced expiration with severe flow limitation. Additionally, the forced expiration can cause turbulent flow in smaller airways in COPD patients. This precipitously drops pressure in the lumen and further narrows the bronchioles. In such patients, expiring against resistance or pursed lips breathing is a technique which makes breathing comfortable. There are certain devices also available to breathe out through that act as resistance. The increased expiratory resistance causes two main things. It increases lung volume and slows down expiration. The increased lung volume is the only way of increasing transpulmonary and trans-airway pressures, thus stabilizing the airway. There is also a general increase in airway caliber that further reduces resistance. The slowed expiration reduces the rate of decrease in pressure from the alveoli towards the mouth because lower flow requires lesser driving pressures. Thus, equal pressure point can be moved further from the smaller collapsible airways to the larger cartilaginous non-collapsible airways towards the mouth. This will prevent floppy airways from collapsing, thus stabilizing the airway and facilitating expiration. And this makes breathing more comfortable for COPD patients. Thank you, sir.
Excellent. Very good. So that's a very, very beautifully described answer for this. Only thing, if you can also draw the picture of what you have said in orally, that will be very easy to understand for everyone. So I'll
Yes.
just try to see whether I have that. Visible?
Yes, sir.
Yes, sir.
Okay. So this is a picture what she has been describing all this while very nicely. So this is a normal person who is trying to breathe in a forceful manner. That is the first thing we have to understand. When you want to talk about equal pressure point, it can happen both in normal and in patients with COPD. In normal patients, they don't normally try to do any forced expiration because their airways are quite patent and they are able to breathe comfortably, so they don't have to force their air out of their lung. Whereas in a patient with COPD, their airways are narrowed, so they have to force every time the air that has entered the lung because inspiration is an active process by the contraction of the diaphragm, whereas expiration is a passive process by the recoil of all the contracted elements. That is the basic thing we should understand. So in a normal patient, inspiration is both in both normal and in COPD patients, inspiration is an active process. So they are able to take the air inside. Whereas in COPD patient, because expiration is a passive process, it has to go through a narrow passage. It requires more effort on the patient to push the air out. Otherwise, they will get trapped in the alveoli, and that causes what is called the intrinsic PEEP, and the alveoli go on stretching, and over a period of time, they will go in for what is called emphysematous changes. So this basic thing, if you understand, then it becomes very easy. So the pressure here, the outside the airway, in the pleural cavity, uh, is always little. See here, the alveolar pressure is 20, and the intrapleural pressure is positive 15. And the same thing here also in a normal patient in the initial stages. But as the air travels from the alveoli to the airway, in a normal patient, what happens? There is a gradual drop in the pressure. From 20, it becomes 18, 16, and when it becomes 15, it has gone to the tracheal or bronchial level where there is a good cartilaginous support. So air is able to go out and goes to the atmospheric level of 0. So it equals the atmospheric pressure. So it travels down like that. Whereas in a patient with COPD, because of the obstruction in the lower airway, the pressure drop occurs much earlier where there is a non-cartilaginous or dynamically collapsible airways, like smaller airways itself, it goes to the pressure gets dropped. So what happens? Patient has to use his muscles of respiration to force the air out, and that is where this pressure point, where it has become equal to the outside pressure, is shifted down towards the alveoli in patients with COPD. Okay, so this is where it becomes narrowed, and that is causing all this problem. So the respiratory system is composed of the conducting part and the respiratory part. The conducting parts are called trachea, bronchi, and bronchioles, which differ in architecture, and both trachea and bronchi are surrounded by rigid cartilaginous support, whereas the bronchiolar, they do not contain any cartilage and tends to collapse much more easily with changes in intrapleural or airway pressure. As a result of airflow resistance, pressure that is generated in the alveoli drops along the airway during expiration. This is also known as friction loss. And when airway pressure has dropped to a level where it equals intrapleural pressure, this is the important step that you have to understand. This is the airway pressure, and this is the intrapleural pressure. When it drops to a level where it equals intrapleural pressure, during forced expiration, an equal pressure point is reached. So the equal pressure point reached in a normal person is in the cartilaginous region, whereas in a patient at the EPP, airways that are not supported by cartilage will collapse. That is what happening here. So in a healthy lung, the equal pressure point will be reached in cartilaginous airway as a result of sufficient alveolar driving pressure and only a gradual drop in pressure due to minimal airway resistance. This is what is happening here. Whereas in patients with severe airway obstruction, resistance airflow will be much greater and the pressure drop will be much more steeper. And what happens? The EPP will move upstream, that is towards the alveoli. It will come towards the alveoli in the smaller airway region and be reached in the thin-walled bronchioles, causing airway collapse and a typical depression in flow volume curve. So this is what is known as the importance of equal pressure points. So the equal pressure point, which is normally in the cartilaginous region in a healthy individual, even during forced expiration, is shifted down to non-cartilaginous lower smaller airways, adding to the obstruction which is already existing in a dynamic fashion, causing increased work of breathing. So that is what we have to ultimately mention. Okay. So that will complete discussion today.